and welcome to the 86th session of ICC Crack the Wellness Code. A warm welcome to all of you. Um, very delighted to see so many of you already joining us, and I'm sure there are already people coming in. So we are going to be having a very productive session, a very engaging session with Dr. Archana Bindra on diabetes care. And she has been very prolific. She had been the past president of APIO, and today she has joined us amidst a major snowstorm that she was stuck with, and she still made it. And we're really glad to have her. This is what we have for today. This is the seventh session of the series of 10 that we have come out with. And many of you have been with us for the past six, so thank you, and that's very heartwarming. And today, of course, we are getting into a very useful and interesting area, which has been getting a lot of attention. There is a significant genetic disposition among South Asians on diabetes. So this is just a topic that a lot of people have been waiting to hear and learn. So this is the learning objective. Broadly, Dr. Archana Bindra is an expert, so she will cover a lot of ground, but these are the four items that we thought if we could get out of her, that would be fantastic, and she'll be happy to focus on them. You can see on the screen that how diabetes can impact in multiple ways, diagnostics and prevention. Then, of course, the best practices, since we focus on wellness best practices, preventive care, lifestyle, diet. So that's also something that Dr. Archana Bindra will focus on, apart from, taking you through, some of the diagnostics and prevention techniques. And then, of course, we are happy to interact with you. And there'll be a lot of tips for our seniors that Dr. Bindra would like to share. So this is today's agenda. And we are again glad to have Dan Maggie for our music, the soulful music that he really charms us, absolutely mesmerizes us. So he's once again here. Thank you, Dan. So, and then of course, Dr. Archana Bindra takes over, and she will definitely, spend a lot of good time. And we are really thankful to her for, spending her time and joining us, although she's just got back to her home after almost very adventurous trip across a snowstorm. So look forward to that. Before I actually get on to Dr. Archana Bindra and the session, I would request Dr. Sachin to introduce Dan Maggie. And you can see his illustrious journey in the world of music. He was born in Los Altos, California, and he has been surrounded by music, and it has been an absolutely remarkable journey. So over to you, Sachin, to briefly introduce Dan Maggie, who of course knows no introduction because he has been with us for so many times, but some of the high points of his career and what he's going to do today to charm the participants is something that we would like to hear from you, and you would invite Dan for the soulful music. Yeah.
Thank you so Dan is with us for many years, like maybe 17, 18 years, almost a decade. And he's a very talented and gifted musician. A lot of you already know him. And he's also gifted with a very soulful music, very calming, peaceful presence. And he also has background into jazz music. He plays flute, also saxophone. And then he also has studied with the Indian classical music, so the raga music and all those into the background. And a lot of his music kind of, it speaks for itself. So, and he's open to new ideas. And since we started these programs, he's integral part of our Happy Monday program. So uh, the rest, I will just leave it to your own experience once you hear him. And every time he comes up with new compositions and new presentations for us. So welcome, Dan, to the Happy Monday. And here you go.
Thank you, Sachin.
Thank you, Dan. This was so mesmerizing. Everybody was spellbound. It really helped us to calm down, and get set for today's session. So thank you very much, Dan. I present to you Dr. Archana Bindra. She's an MD FAC, and is a board-certified endocrinologist with expertise in diabetes, thyroid diseases, and metabolism. She's based at Fremont, California, and is affiliated with the Regional Medical Center of San Jose and other hospitals in Fremont. Uh, she was previously the director of diabetes at Washington Hospital Healthcare System since 2011, and currently she is with El Camino Hospital at San Jose. She received her medical degree from the St. J.S. Medical College and specialized in endocrinology from UCLA, and she acquired and did her fellowship from Cider's Sinai Medical Center. Her specialties include endocrinology, diabetes, metabolism, and internal medicine. She has presented in various wellness aspects of diabetes and moderated several panels for ICC Crack the Wellness Code. She has been the previous president of RPO, and she has also devoted significant amount of her time and enthusiasm in community service, helping, not only a network of doctors, but also the network of CWC. So having said that, welcome to you, Dr. Archana. You can see that there's so much of enthusiasm today, and people have started getting into this program even before we hit 6:30. So they're all waiting to hear from you. So over to you.
Thank you so much, Som, for that kind introduction. And thank you for the beautiful music. That was truly inspiring, especially after a week stuck in a snowstorm. So what is diabetes? I've been in practice for about 15 or 16 years, and most of my practice revolves around diabetes. And I see a lot of patients on a daily basis, and from what I've learned from seeing them is that they have it for a long period of time, but not many of them actually know what to do about it, what's going on with them, and so forth. So the talk for today is a very basic diabetes talk. I will speak for about maybe 20 minutes, and then at the end of that, we should have enough time for questions. Of the 4 topics that were mentioned previously, if I don't touch upon some of those, I'm happy to take questions at the end. So get your questions all ready. And because this is what I do pretty much day in and day out. So diabetes, essentially, your body basically requires insulin to transform your glucose into energy. And the question is, where does that insulin come from? Insulin comes from the pancreas. And this is an organ that's sitting right here in the middle of your stomach, the pancreas, which has something called beta cells that secrete insulin. And how does it work? So when your blood glucose is very high, it tells the pancreas that we need the insulin to be secreted, which then in turn brings it down. And then when it's low, the pancreas also secretes something from the alpha cells called glucagon, which then brings it back into the normal range. And therefore we create what we call a homeostasis, which is essentially a normal level of glucose. And it's carried out by the balance of these 2 hormones, insulin and glucagon. Now, this is in a normal person, and it happens on a daily basis without you thinking about it. So when we were born and we were essentially gone through evolution, the point was that we would not lead a sedentary life and that we would be very active and we would maintain a normal weight. So technically a normal weight or a normal BMI for an individual is less than 25. That would be a normal weight for an individual. And even less than 20 would be even better, somewhere around 19, 20, 21. But if you're less than 25, you're doing well. Now, if you start crossing that range and you start reaching towards 30, you're actually reaching towards obesity, and as you can see over here. And the problem with it is that it's not just that you don't fit into clothes and you can't go to a mall and buy what you want. It causes much more problems that come along with it. And the problem that we see is diabetes. So there are 2 types of individuals that are out there. One is an apple and the other one is a pear-shaped. So as you can see that the apple is sort of entirely round, but the pear-shaped is as a pear. So the apple essentially has a lot more what we call subcutaneous fat and abdominal fat, but the subcutaneous fat in a pear is differently shaped. It is this, what we call the subcutaneous fat, or this visceral fat, which is what causing all our problems in diabetes. And it also leads to something called insulin resistance. Now, what is insulin resistance? Insulin is needed for glucose to get inside the cell. So essentially, insulin is like your key to help this glucose, this person, get inside this cell. And if this keyhole is all stuck with all the cholesterol and everything that's got laden in the body, and it's clogging it up, then that insulin doesn't fit into that keyhole. The glucose doesn't get inside the cell. And what we have is a whole lot of glucose floating outside, leading to diabetes. And that glucose in turn causes a lot of damage. So when we say that we've gone to the doctor and we've been diagnosed with diabetes, which is at this point when you got diagnosed, say at 0, you've actually had diabetes for a long period of time before you were diagnosed. And usually that's about 10 years. So it's already gone through different phases. And then finally, when you're diagnosed, you've already had it for a good amount of time, and your beta cells have already started to falling. So when we get diagnosed, we lost 50% of the beta cells already. And when people check their blood sugars, the first thing they check is in the morning. But guess what? That morning blood sugar has been high for a long period of time. The first thing that really rises are your post-meal blood glucose. It's the post-meal that rises and starts going up. The fasting blood glucose actually rises afterwards. So by the time you start checking and looking at your fastings going up, you already had it for a long period of time. And by the time you actually start controlling it, you start developing insulin resistance. So when the beta cells start beginning to fail, the insulin resistance starts beginning to rise, and that starts plateauing out. And you'll start noticing that patients' insulin is not being able to be secreted enough to overcome the rise in the blood glucose that continues to take place. And that's when people start noticing that they have high sugars when they check on their monitors, and that is diabetes. So what happens when you have diabetes for a long period of time? So essentially, obesity and insulin resistance are your biggest problem factors for developing diabetes. And that, of course, is brought about by the environment that we're in, the kind of nutrition that we eat, whether we're getting any physical activity or not, our genetic susceptibility, our parents, whether we came from a family of a lot of people having diabetes, which is very common in an Asian society, where a lot of parents have diabetes, grandparents have diabetes. Our environment and our nutrition is very prone to diabetes. Most of our meals have a lot of carbohydrates. We have roti, we have rice. Most of the things are carb driven. And a lot of our activities are very sedentary. So unless we are very, very active and we start exercising on a regular basis, invariably insulin resistance is inevitable, and most people end up with prediabetes. So when we say impaired glucose tolerance, the IGT here, that essentially is prediabetes. And that can definitely be reversed as long as people change these few factors that are involved in making it get worse. So once a person actually does develop diabetes at this point, then it's a question of just having ongoing hyperglycemia. And what that means is that you have what we call atherosclerosis, which means that it's going to start clogging your vessels. It develops hypertension. You start getting the complications of diabetes. You eventually get kidney failure, blindness, leg problems with less sensations. People end up having amputations. And that's a grave form of disability, which eventually, of course, people then succumb to dying. So the main part of this whole thing is, how do you stop it at this point? And that's where that is basically their sense of treating diabetes. But nowadays, a lot of people come to me, especially, they come in this phase of complications. I see a lot of people in this phase as well. And then the question is, how do we just keep it from getting worse? How do you maintain it at a certain range? And there are lots and lots of people who actually are able to reverse it, even at this point. So it's not like you should give up if you are in these stages, because you can still modify a few of these factors. You can't change your genetic susceptibility, but you can definitely change your environment and the food that you eat and the exercise that you perform. So how do we diagnose diabetes? Diabetes essentially is a blood sugar above 126 as a fasting blood sugar. On a 2-hour or glucose tolerance test where we take a drink that contains glucose and check the blood sugar at the end of 2 hours, if it crosses 200, like over here, then we call it diabetes. If it lands somewhere between 140 and 200, then we're still in the pre-diabetes form. And in the morning, if we check it and it's between 100 and 126, we're still in the pre-diabetes form. So if you're less than 100 in the morning and you're less than 140 at any given time of the day, especially after a 2-hour meal, then you definitely don't have diabetes. So what is a hemoglobin A1C? A hemoglobin A1C tells you what your sugars run like. So where you want it to be is less than 6.5 to say you don't have diabetes, but you want it to be less than 5.7 to not even have pre-diabetes. I'm sorry, it's not mentioned on the slide. And as we go into the higher range, it just gets higher and higher, corresponding to extremely high blood sugars. So if you were having a blood sugar of 10, A1C of 10.0, the blood sugar would correlate to about 250. And an A1C of 13 correlates to 350. And an A1C of 6 correlates to 115. So what we're trying to say is that if you have a lot of high blood sugars and a lot of low blood sugars, generally your average will be pretty good. So an A1C is a nice indicator to go by, but you cannot rely on it absolutely unless your blood sugars are always in a stable form. If someone doesn't understand this, then I'm happy to explain this a little bit later as well. But basically, if you have a lot of highs and a lot of lows, your average would be pretty good. So how do we monitor our sugars? It's very important to check your blood sugars, keep a log of them, monitor them in some form, and before you go to your physician. I used to, when I finished my residency and fellowship, I started seeing patients, and I had a lady who once came to me with a book full of very well-written blood sugars. I mean, they were all like 100, 90, 110, but her hemoglobin A1C was 9. And it sort of perplexed me as to how can her A1C be so high when all her numbers are so good. And from that day onwards, I started to make a rule that if you don't bring your glucometer with you, I will not see you. Because if I don't see your sugars, I don't know how you're doing. And so I have kept that from that date onwards. So it's very important that you check your sugars, and not just once, maybe 2 times, 3 times, to see how your numbers are doing. We used to use the monitors, we still use, and essentially it's a prick of blood. You place it on your strip and you get a number. And that number to you is a number telling you, indicating how you're doing. So if you see a number that's very high, it's a number to tell you that, oh, maybe what I ate for breakfast or lunch was probably not the best. And I should probably change that and eat something better, or take away maybe a few carbs, or substitute it with a better meal. Now, the talk is not long enough to go into the details of nutrition in this talk, but essentially we're just talking more about basic management and care for diabetes. So nowadays, I'm sure most of you have heard about continuous glucose monitoring systems. There seem to be a lot of advertising on TV. The most common out there is the Freestyle Libre Pro system, as the one that you see here. The Dexcom is a little bit more of something that you would need to actually, both of them you need a prescription, but the Dexcom is a little harder to get. But the Freestyle is very easily available. And one, along with the prescription, one can actually just pay for it and buy it. And the way they work is that it's important to get an entire picture of how your blood sugars are doing. So when a person checks their blood sugar once or twice a day, all that they're seeing is a blood sugar at that time only. So in the morning, the blood sugar, if it was checked and it was 130, then that's all that you know about yourself. And in the evening, if it was 260, then that's all you know about yourself. But you didn't capture all these that happen in the interim. And that's very important. So a lot of people go low during the night. So like this person is going really low so many times in the day, and that person really doesn't even know about it. But that person is also having this extreme spike and they don't know about it. So 70% of individuals have unrecognized hypoglycemia, which means a very low blood sugar that occurs at night. And even with frequent testing, very often we can miss this hypoglycemia. But when we have something that's continuous, it definitely picks it up. And how do we place this? So it's a little tiny apparatus that's placed on your arm. It's the size of a quarter. And essentially, it can be placed in your doctor's office, or you can be placed by yourself at home. It's very easy. And what it does is it gives you this kind of a graph of what's going on with you. So the broad lines tells you that you could be varying in your blood sugars at different times of the day, but your average blood sugar runs where this dark line runs. And you can see how varied the blood sugar can be throughout the whole day. And this is somebody with an A1C of 7.8. And they also talk about something called time in target or time in range. It's very important that you know how long in the day that you are actually in range. And it shows that you're in range only for these many hours. The rest of the time, this person is all over the place. So essentially, this will measure a blood sugar every 15 minutes on its own. You don't necessarily have to have any interaction with it. It does it on its own entirely. The more you swipe, the more you'll see. That's for sure. You wear it for 14 days. Take it off. It's as easy as removal of a Band-Aid. And then you put a new one on. The sensor data gets downloaded. You could re-download it at the office, take a look at it, and then we get an entire idea of what's been going on. And this is exactly how it is. It gets applied, it's recording, it gets downloaded, and then we interpret it. And these are the kind of graphs that we get. We talked about that a little bit before, where you can see the trend of it. You can see how much you vary in your blood sugars. You could see if the person has hyperglycemia or not. It gives you lots of information in a very single 24-hour picture. So why do we care whether these sugars are high? There was a study performed in 1996 or 7, and it was called the DCCT, the Diabetes Control Trial, essentially, which looked at microvascular complications. Now, what are microvascular? They're the small vessels of the body. So they cause eye damage, which is retinopathy. They cause kidney damage, which is nephropathy, which is a neuropathy, which is leg damage, nerve damage to the leg. And microalbumin is when you start pouring out protein in your kidney. And all of these start happening when your A1Cs are high. And you can see that it starts happening just about at 6.5. And if you don't take care, then these start really soaringly rising high, of which retinopathy has the highest lead, followed by your kidneys. So it's very, very important in diabetes to take care of the ABCs. And actually now there is one more, which is S, which is stop smoking. But the A is essentially your A1C. You want it to be at least less than 7, but 6.5 is the best. You want your blood pressure to be less than 140/90, or even 140/80. And your C is your cholesterol, where the LDL should be less than 100, or sometimes even less than 70. So these are very important. So if you haven't been following these, then it's good for you to, when you go to your physician, to tell them that I would like to know what my blood pressure is. I want to know what my LDL is. And your goal is to stay less than 100 for LDL, or even less than 70, less than 130/80, or a minimum of less than 140/90. and a hemoglobin A1C less than 6.5. So what are the complications? We talked a little bit about microvascular complications, and diabetic retinopathy is probably the leading cause of blindness in diabetes. So it's very, very important to get your eyes checked on a yearly basis. So if you haven't gone to see somebody for a year, then make an appointment. Diabetic nephropathy is a leading cause of kidney failure from diabetes. And diabetic neuropathy is when you have nerve damage and people tend to lose their sensation in their feet. I had a patient years ago who had gone to Vegas. He had very bad diabetes, A1C of maybe 10. His sugars were in the 300s all the time. And the man walked around in Vegas in the summer heat barefoot. And essentially he could not feel the ground. And he said he would always be walking on clouds. That's what he would say. So this is somebody who had such bad diabetic neuropathy that he lost his legs eventually because he had third-degree burns from all that heat that he could not sense at all. The macrovascular complications are strokes. Strokes are very common in people with diabetes. Heart disease is common. Peripheral vascular disease, where your vessels in your legs get clogged up. And smoking, of course, makes all of this extremely horrible and worse. And it speeds up the process. So the foot exam, let's talk a little bit about that. It's very important to not walk barefoot when you have diabetes. Always wear shoes, always wear something that has a cushion. There are socks that have cushions. There are diabetic shoes that are available. It's important to see someone called a podiatrist who takes care of your feet, because it's very important to know that you can have loss of feelings in your feet. You can feel that they're tingling or they're burning, they have numbness, if they have this sharp pain that comes and goes. Sometimes you feel that you're hypersensitive. These are all the signs of what we call peripheral neuropathy. It's very important. It's very important to keep your feet, you look at them every day, keep your toes dry, look even between the toes, make sure that they're taken care of. And these are the points, the different points that we want to look at, because these are the points that touch the ground when you walk. And we use something called a monofilament, which is this thing, which literally doesn't hurt at all. It just sort of bends and pokes to see if you have the sensation or not. If your doctor doesn't do it, you can go and take off. The first thing I ask my patients to do is take off your shoes as soon as you sit down, because I want to see your feet. It's very important. This is a foot ulcer that one can develop, especially when you don't have good circulation and peripheral vascular disease. And you can see that it usually happens in areas of most friction. So shoes that are well-fitting are extremely important. It's always important that we start checking our feet at an early age. An eye checkup once a year, very, very important. So they're telling each other that if they only had their regular eye exams, they won't be blind. So what are the different stages of nephropathy? Nephropathy is when you start having protein spilling out in your urine. So when diabetes is uncontrolled, the first thing that the body likes to pour out is protein. And it's called microalbumin. So that's something that we check on a urine report. And you don't want it to cross 30. That means you started to dump protein in your urine. It's very important. And once you start dumping more and more, then your kidneys start worsening, and eventually you can end up on dialysis. And the primary cause of kidney failure, this was in 2005 and it's only got worse, is essentially diabetes. The second highest is high blood pressure, and then all the rest. So we all worry about high blood sugars, but low blood sugars can equally be a problem. There are lots of patients that when they have a low, they overreact and they drink sodas, juices, they'll get a candy bar, they get all kinds of things, and their low blood sugar of the 40s or 50s goes all the way up to 300. So it's very important that you don't want to overreact, but you want to give yourself just about enough to bring it up to about 90 or 100. And how do you do that? So the most important is you check your blood sugar. That's the first one. After that, whatever number you see, if it's 60 or 50, don't panic. Have something ready. Keep a small orange juice, the little ones that kids take to school with them, Those little cartons have 15 grams of carbohydrates. And that's what you really need to get your blood sugars up. You need 15 grams. You basically, you take it, you wait 15 minutes, and then you recheck your blood sugar. And if it hasn't gone up by, from to the level that you want it to go, then you repeat it again. But by the time you reach about 90 or 100 is when you stop doing this procedure. And we have to remember that this is a treatment and not a treat. So it's not the time to go and get a Snickers bar or some kind of a candy bar for yourself. So how do you get the 15 grams of carbs? You can either have 4 ounces of orange juice. You could have 3 glucose tablets. Each one has about 5 grams, 4 grams somewhere. You can have 6 to 7 hard candies, which I don't think very many people would do, or a spoon of sugar. But essentially, if you have milk in your house, orange juice, something like that, all you need is 4 ounces. You don't need an entire bottle. It's also very important to have glucagon. It's an emergency treatment of hypoglycemia. So the person whom you're living with or yourself, especially if the person is unconscious, then this is something that comes sort of semi-formulated. You have to sort of mix it and then give the person a shot, which will wake them up. There's a newer one out there. It's called Baqsimi. And what it does is it's an inhaled form. All you do is you put it in the nostrils and you press it and you get a puff of medication and it brings up your blood sugars. So essentially diabetes is very important. It's a multidisciplinary team. So you see someone like me who is an endocrinologist, and I work with a diabetes educator who does all my training and teaching of nutrition and so forth. I also work with a podiatrist who checks your feet, work with an ophthalmologist that you see on a yearly basis. You want to see an exercise counselor so that see how much you can, how much are you able to run and so forth. And a pharmacist to go over all your pills, your insulins, and make sure that you're taking stuff correctly. And I think that's the end of my talk. I will stop sharing and I'm happy to take questions.
Thank you, Dr. Archana Bindra. That was great. I think you made a huge sweep within such short time. And, there are multiple complications that can happen. I think you covered all of them. So let's get started with the questions. A lot of questions I saw were on A1C. And the first one was, should we start treatment when we see A1C is around 6.5?
So I think that's a very good question. In fact, when people are at 5.7 and they become pre-diabetic, it's important to consider, especially if you have a family history of type 2 diabetes, you would want to start maybe thinking about, at least if it's not just diet and exercise, then adding maybe metformin at bedtime just to help with the morning blood sugars. But if you don't have a family history, then this is a good time to make some good lifestyle changes, and exercise and diet would be the foremost.
The second one is also around A1C, which says if your A1C is less than 6, would you consider yourself diabetic or just not?
Yeah,
worry?
So it's similar to what the previous one was. You would definitely want to take care of yourself, because if it starts approaching 6, then it's only going to be creeping up. So yes, so pretty much diet and exercise, lifestyle changes become your prime.
Yeah, the next one is we have a lot of media against wheat these days. Do we have any diet plan without gluten-laden wheat roti?
Yes, definitely. There are lots of plant-based diets that are available that do not necessarily have to have wheat in them. In fact, wheat is it's not encouraged. And so you would want to go in favor of other grains and use them instead of wheat in order to create similar kind of, like rotis and things like that. So, or find a different form of medium to cook food. And then, of course, I think nutrition would be a whole different topic.
So the next question is, can you talk about discrepancies in CGM and fasting blood glucose readings and how to reconcile? That's the first part. The second part also, so I'm just stopping on the first part. How do you reconcile this discrepancy?
Sure. So when we use a CGM, we have to remember that they go inside interstitial fluid versus when you're checking your blood glucose from your fingers, it's coming from capillary blood. So when the food goes into the system, it goes first into the bloodstream and then it will go into the interstitial fluid. So that fluid is always following the blood glucose by about 10 minutes or so. The newer freestyles that are available, the Freestyle 2 is now more in real time as compared to the other one that was sort of like lagging behind. So you would see that the CGM would give you maybe a reading of 90, but the actual meter will give you 130 and so forth. But now we have less of this discrepancy. And unfortunately, there's not much of a way to go around it.
Okay, great. So the other one is a very straightforward question. It's about a correlation between intermittent fasting and diabetes management. What is your take on that?
So I think if one's A1C is on a lower side, like if you're in the 7s or the 6s and you want to do intermittent fasting, then yes, that is certainly something that you can do. You just have to take care that you're not on medications that would make you have low blood sugars because you will be fasting for 16 hours. But if you're on insulin, it might be a little bit of a challenge to do intermittent fasting because you would have to eat at a certain intervals in order to get your insulin, and that might pose a problem.
So the next question is, does diabetes cause glaucoma?
Diabetes causes glaucoma, it causes cataracts, it causes retinopathy, it causes macular degeneration, it causes just about anything in the eye.
How much is the cost for Libre 2 machine, and then does Medicare has coverage for it?
Yes. So the Libre 2, so the older one has a sensor and it has the reader. So the sensor component, now the reader for the older one could be your phone. So you don't need to pay for that one, of course. But the sensor, the actual round thing that's, the quarter size thing that we were looking at, that sensor cost about $50 to $60 for every 2 weeks. So it's about $100, $110 per month. Medicare has been covering it now because of COVID. So if you really want to get it, it's a good time. Otherwise, Medicare wanted people to be on insulin and checking blood sugars 4 times a day, and they wanted records, and even then they were giving a hard time. But otherwise, all private insurances, commercial insurances have been paying for it. But this Libre 2 has a sensor which needs a reader. So that reader costs another $60. So essentially that's your one-time payment. And then your sensor will be again about $100, $110 a month. So it's like one ticket to India, basically, if you think about it.
Let me go to the next question. My fasting blood sugar is 86 and A1C is 5.9. What changes should I bring?
So essentially you're in the pre-diabetic stage of 5.9. Fasting looks pretty good, but I would encourage you to check yourself during the day as well, maybe a couple of hours after your meals. And I think just good diet and plenty of exercise should bring it down.
Yeah, the next question is very interesting. Does apple cider vinegar help lower morning blood sugar? That's the first part of the question. And what is dawn phenomena?
Yes. So apple cider vinegar, whether you have, there are people who take all kinds of things like cinnamon, they say jamun, there's all kinds of stuff that actually brings down your sugars, and those are fine. Dawn phenomenon is in the morning when one gets up, their blood sugars are high, and those blood sugars are high because there are lots of hormones in your body that are trying to essentially get you out of bed. So if one would think about it, that if you were to go to sleep at, 9 or 10 o'clock, and if you were not eating for almost 10 hours, something has to keep your body going. So your liver makes the glucose, and the glucose that is made is not been able to be combated with the insulin released in your body to keep it low. So there are lots of hormones in the morning around 4 o'clock like cortisol, growth hormone, epinephrine, they start getting released in order to increase your sugars and help you to get out of bed. And that in the morning is called the dawn phenomenon because it happens early morning.
The other question is that eating rice every day, does it enhance the risk of diabetes or anything that can trigger diabetes?
So eating rice every day, rice essentially is a carbohydrate and a starch, which essentially is getting converted to glucose. And it does, in some people, it will have no impact. And on some others who have a genetic predisposition, or if you're extremely obese and you're eating rice, then it's going to cause trouble. So it could go from person to person.
Okay. Then the next one is that is there any threshold age that you cross that age, then the risk of diabetes go up?
Well, I would say it's maybe in your 30s, you might start, considering being checked. Or if you have a family disposition, and you might want to be checked even earlier, but essentially it can happen at any age.
Okay. What vegetables, fruits would you recommend for diabetes? Somebody who's diabetic with A1C 7.
I think you can pretty much eat all the vegetables that you like. You probably vegetables should not be much of a problem. Corn can sometimes be an issue, but fruits, I think the berries do better as far as the glycemic index as compared to some of the others. So maybe the grapes and the watermelon, the pineapple, the citrus fruits, they sometimes cause a lot more problems. But if you were to eat more of apples, uh, they say more of crunchy fruit cause lesser problems with sugars. The berries definitely have a lower glycemic index.
Okay, so the next question is more like a comment. It says that our health program doesn't allow us to label DM unless A1C is greater than 6.5 for CDM, even when we are managing prediabetes. Any comments on that?
Yes, the CGM unfortunately has not been covered for pre-diabetes. So I do give it to some of my patients. We get samples from the company, and we sometimes start it on some patients if they're very, very highly motivated. And some people just offer to pay for it.
Is banana good for diabetes?
It's probably not one of the better fruits, especially if you have a high A1C. A high A1C, most of the fruits tend to be a problem in order to bring it down. Once I think your A1C has been brought down, then you can start introducing different fruits.
So the next one is any specific exercise would like to recommend for reducing sugar?
I think walking is probably the best. I keep hearing people saying that the gyms are closed and I can't go and I can't do this. But I think if you just tell yourself that you want to do 2 miles a day and just walk every single day. I've actually had a patient who was 26 or 27 years old, and he weighed 230 or 240 pounds, maybe 240 pounds. And this boy was drinking sodas and juices and all kinds of things. And he came in with his girlfriend, and he looked so scared. He was on 80 or 90 units of insulin. And I told him that you're 26, you can do something about this. We need to change you. So what we did was we got rid of the soda, we got rid of the all the bad stuff that he was taking. And just getting rid of the bad stuff, he lost 30 pounds. And after that, he started running. So he would go to college by bus. So he decided to go halfway running and then halfway by bus and it was, I think, 12 miles or something. So he ran for 6 miles every single day. The boy lost more than 100 pounds. And he did this all by himself. And he was off of all insulin. Of course, I think he also lost his girlfriend in the process because he never went out to dinner. So, but I think in the end, he's so much more healthier and happier. And, and I don't know where he is now. Otherwise, I would have made him a part of Crack the Wellness Code, but I have no idea. But this is one kid that was extremely inspiring. I mean, to lose 100 and more pounds just on your own. So if one really wants to get rid of it, one can. And I think just walking every single day, 45 minutes, half an hour to 45 minutes is very, very important. Do that 5 or 6 days a week, and you will see a difference.
One question means I had pretty much answered by most people's concerns are like, can we eat fruit or no fruit? And the main theme is how the routines can help, or is there you see any seasonal changes affecting the diabetes or any patterns like that?
I think, of course, winters definitely make sometimes difficult for people to go exercising and so forth. People want to have, with the fruit seasons, make it hard, especially when the summer arrives and you have all the nice citrus fruit and everything. But it's important that if you're going to eat a fruit, make sure you're not eating more than one a day or two a day, especially if your sugars, A1Cs are high. If your A1Cs are 6 or 7 and you want to enjoy fruits, then just make sure you're getting a lot of exercise to keep that A1C low. That's very important.
And what do you think of all these new machines which are getting launched, like the Peloton and things where you do the exercise?
I think if you can afford it, it's a great way to go.
Yeah.
They're also very expensive. So, I mean, but the cheapest form is to walk. I have a lot of patients. I mean, you're not going to get on a Peloton if you don't want to walk.
Exactly. Thank you.
So I think walking is the most basic form. So if you I said, just go out, go around the block, time yourself and go for a 2-mile walk. That's all you need to do. I think if you do that, then you may get onto a Peloton, because otherwise after a week, you're going to say, I don't like that anymore either.
And
Yeah,
any resources would you like to point to people which they can monitor on their own, like apps or some?
Unfortunately, I haven't been much of an app person. My son says that I'm very outdated. But I think that if you have a Fitbit or something, and at least you count your steps and you know how much you're moving, that's very important. I've actually managed to put something on my phone so it keeps track of me, because my phone goes somehow wherever I go. So at least I'm able to know how much I've accomplished in the day.
And the last one more idea is that because of the corona, a lot of people are spending time indoors, and a lot of that becomes screen time, and it not just sitting physically but also mental stress and things.
Right.
So any tips you would like to offer?
So diabetes is definitely a risk factor for, so the myth is that if you have diabetes, you can get corona more, which is incorrect. You have, your risk is as much as anybody else, but if you were to get it, your risk of doing well with it is less. Yeah. I mean, you're not going to do as well and you may not recover as well. So that's why you don't want to go get it. But that doesn't mean that you cannot leave your house, wear a mask, and walk.
The slow walk versus the brisk fast walk.
A brisk walk, a 30-minute to 45-minute brisk walk about 5 to 6 times a week is what you want. You want to get about 150 minutes in, the bare minimum.
So, Dr. Archana, Bindra, once again, I want to tell you that there are lots of, thank you messages to you. So this has been an
Very much.
awesome session. And that also in midst of so many challenges, they could finally make it and join us. This is great. Of course, the video of this session would be very valuable to all. So we definitely preserve it, and of course, we'll make sure that those who couldn't join this session are able to get access to this information. So thanks to everybody once again.